Hello and welcome to the breakout session on Hodgkin lymphoma. My name is Jumana Khouri, and I'm the Fund Development Director at Lymphoma Canada. I'll be the facilitator for this session today. I'm pleased to welcome here Dr. Joanne Hickey, who will answer your question from the breakout session on Hodgkin lymphoma. As a reminder to our audience member, please type your question into the Q&A box or the chat box in the middle of the black toolbar at the bottom of your screen. We will try to answer as many questions as possible. Okay, and we will start with the first question here. As a young woman diagnosed with Hodgkin lymphoma, what fertility preservation option should I consider before starting treatment? Are there specific timeline for initiating these processes?
That's an excellent question. It's something that we as lymphoma treaters always consider when we're talking to our patients of childbearing age, female and male. Of course, it's more challenging for women in terms of fertility preservation. I always defer to my fertility colleagues. You know, they are the experts. So I think the most important thing is getting to speak with your local fertility experts as soon as possible. One of the challenges in terms of fertility preservation for women is that it can take some time, of course, because egg retrieval is not always available in all locales. It does require timing with a cycle. It requires hormonal stimulation, etc. We unfortunately don't always have time to wait, depending if a patient is unwell with their lymphoma, or of course we would discuss that with them. But there are other options. Again, one positive thing about where Hodgkin lymphoma treatment has moved over the course of the last 30 to 50 years is that at least upfront treatments typically are not as risky or not significantly risky to fertility. But of course, you know, as a young woman who wants to have a family, you're thinking about what if I have to move to different options. You know, it's a good thing to think about upfront. Talk to your doctor, but sending you to talk to the experts, the fertility experts. But those are things we always think about.
Right, thank you. We also have another question, which is what tests or evaluation are typically conducted to assess the effectiveness of treatment for Hodgkin lymphoma, and how often are these done?
Sorry, could you just repeat that again?
Sure, it's about the what tests or evaluations are typically conducted to assess the effectiveness of treatment for Hodgkin lymphoma, and how often are these done?
So probably our biggest disease response test is the PET scan. As I sort of alluded to in my talk, it shows both sort of anatomic size, but more important, sort of functional response of the lymphoma. It's like any test, it's not a perfect test. I always tell patients, you know, even a complete metabolic remission does not guarantee that a patient will be cured. But the PET scan gives us our best information, and also, you know, also is important in terms of making treatment decisions. So how often it's done will depend on your treatment regimen. So usually done after sort of 2 to 3 cycles of chemotherapy, and then again at the end, but it's very variable. Just like I sort of chatted with in my talk, it depends if you have early stage Hodgkin's, advanced stage Hodgkin's. There's, you know, variation in the type of protocols or that can be used. So that would be how often it would be done. Post-treatment, in terms of surveillance, really are chatting with you, doing blood work exam, what we call a clinical assessment is what we rely on most in terms of looking for relapse. But certainly if we're concerned about relapse, a PET scan is probably the thing that we rely on the most.
Thanks. We received another question here. It's about, are there any complementary therapies such as lymphatic massage and acupuncture that would be recommended for a patient undergoing treatment for Hodgkin lymphoma? And are there any risks associated with these therapies?
It's an excellent question. I think in terms of anti-cancer treatment, the treatment that we have the most evidence on is the treatment that we talk about in terms of chemotherapy and radiation. Other alternative or complementary treatments, some people will ask about vitamin supplements, dietary changes, lymphatic massage. I don't think we have robust, sort of like I talked about in that talk, clinical trial data to say that they are effective from an anti-cancer perspective. That being said, there are a lot of things that can help a person's wellness, and that goes hand in hand with treating the person. Whether you think, your ability to get through treatment is going to be better if you feel better and have the supports that you need. But I do think you have to be cautious in terms of complementary treatments that are specifically medical or procedural, because there's a possibility of an unknown interaction with your anti-cancer treatment. And that's where you really need to talk to your doctor specifically about the kinds of things that you have in mind. Like, as an example, a general massage is probably not going to be an issue. When you said lymphatic massage, I'm not sure what that involved. And so I'd probably want to know a little more information about that.
What does the term being fit enough for treatment involve?
That's an excellent question. So it's a holistic assessment. We look at the patient's medical problems they might have previously. So for example, one of our chemo drugs can be hard on the heart, what we call cardiotoxic. So we have to do a heart test to make sure your heart is strong enough to get that medication. If you can't get that medication, there are other things that we can do. So we look at a variety of organ function to make sure that we're not going to do more harm than good. Again, I always say it's never about withholding a treatment from somebody. It's always about trying to make sure that our treatment is benefiting and not going to do more damage. The other thing we look at is sort of just a person's overall wellness, what they're able to do in a day. So it's not just one thing. It's looking at the entire person. And there are some treatments, because of their side effects and how hard they are on the body, that there's a concern that it may do more harm than good. But if that's the case, then there are other sort of less intensive options that we could consider. And we discuss that with you on an individual basis.
Yeah. So what steps can be taken to expedite the diagnosis of Hodgkin lymphoma, especially for young patients who may face delay or misdiagnosis?
And that's a challenge. It's I think I sort of alluded to a little bit in my talk, if you had a chance to look at it or to watch it. One of the challenges with so all cancer diagnoses require a biopsy, and how easy it is to do that biopsy depends on where the cancer is or where the enlarged lymph nodes are. If a lymph node is in the neck or under the arm where it's easy to get at, it's a much easier diagnosis. If it's inside the body, in the chest or in the belly, then it could even require a surgery, a more invasive procedure. One of the important things with Hodgkin's is that the biopsy be a large biopsy so that we can really see, see the full lymph node to kind of get the full diagnosis. One of the things about blood cancers, we never want to delay in diagnosis, obviously, and certainly not an extreme delay in diagnosis, but these lymphomas and blood cancers tend to be what we call systemic diseases at the beginning, because the lymph system lives in your entire body to begin with. So it's a little different from the concept of, a solid tumor, like say a breast cancer or bowel cancer, where it starts in one place and then it spreads. And if it spreads to multiple places, then it's not as treatable. That's not as important in lymphoma. It's still important. Obviously, we certainly don't want time to go by and people to get sicker and sicker with the lymphoma and be less fit for our treatment. I think the the most important thing is to get a big biopsy. But again, that can be challenging depending on where the lymph node is.
Yeah, thank you. And what follow-up care is typically recommended after completing treatment of Hodgkin lymphoma, and how often should I expect checkups?
Every center is a little bit different. On average, the follow-up is probably going to be in the every 4 to 6 months in the first few years, probably every 4 months in the first 1 or 2 years, because that's the highest risk time for relapse. And then after that, it often goes to every 6 months and then maybe even every year. And we usually follow people for about 5 years after treatment. What's, as I touched base on previously, the mainstay of that follow-up is visiting your doctor, a discussion, what we call a history, where we look for symptoms that are worrisome, an exam where we feel, do we feel any lymph nodes, some basic blood work, and then we make decisions on do we need further tests, like CAT scans or PET scans based on that.
Would you be able to discuss the treatment of Hodgkin lymphoma looks like for the pediatric population?
I apologize. I'm an adult hematologist, so I'd be speaking outside of my area of expertise, so I can't speak to that today.
No worries. And the other question we received is about to differentiate between lymphocyte-rich and lymphocyte-depleted Hodgkin lymphoma in terms of overall projection and treatment options.
So lymphocyte-rich and lymphocyte-deplete, so all classical Hodgkin's lymphoma are treated the same. The one category that's treated a little bit different is this, or is considered differently, is not always treated differently, is the nodular lymphocyte predominant Hodgkin's lymphoma. That is that's this non-classical Hodgkin lymphoma. Over years, we've learned that may be more like a non-Hodgkin's lymphoma, and we're incorporating some non-Hodgkin lymphoma treatment into that. But still, the mainstay of treatment for that particular type is quite similar to Hodgkin lymphoma, because again, that's all our clinical trials to date have been done treating that as a Hodgkin. But lymphocyte-rich, lymphocyte-deplete, they are all classical Hodgkin lymphoma and would be treated the same.
Yeah. Are there some predisposing factor that put me at a greater risk of expectancy, neutropenia as a result of treatment? And what measures are taken to monitor and prevent this?
For neutropenia, I guess most of the chemo regimens, or the upfront chemo regimens, sort of the classical cytotoxic regimens, do have an increased risk of neutropenia. Almost all of them will cause some degree of neutropenia. So patients who are, again, the risk of neutropenia has a little bit to do, I guess, with the healthiness of your bone marrow. And in general, as people get a little bit older, there's a higher risk that the bone marrow doesn't work quite as well as when they were younger. So they may have a higher risk of neutropenia and potentially a higher risk of side effects related to that. The main treatment is there's medications like Grastifil or Neupogen. They're based on body hormones that can boost the neutrophil count, and that can be used in between chemotherapy cycles to sort of decrease how long a patient has low neutrophils. We don't always check to see if patients are neutropenic in between cycles of chemotherapy, because we kind of know that they're going to be. And if they're not having infections and their chemo can be delivered on time, they don't necessarily need these growth factors. We primarily check blood counts before each round of chemo, if we're talking about upfront, like ABVD. And certain protocols as well. So for example, the brentuximab AVD, because that has a higher risk of neutropenia, that has those growth factors built in, so you'll always get those injections to try and decrease the risk of neutropenia. Hope that answers your question.
Thank you. And what are the most common indicators of relapse in Hodgkin lymphoma, and how are they typically monitored during follow-up visits?
So it's quite variable. It could be, so in terms of how it's monitored, again, it's a full history, physical, and blood work. So what a history is me asking you questions. So asking about those B symptoms. Do you have any drenching sweats at night, any new unexplained fevers, any unexpected weight loss? Have you noticed any new lumps or bumps? So new lymph nodes, of course, would be a worry. And then asking questions about what might suggest lymph nodes that are big on the inside, like a cough, pain, belly pain, troubles like that. Sometimes there are clues that we can, obviously, when I give you a check over, if I feel lumps or bumps, that will be a worry. If I feel lymph nodes that are enlarged, and sometimes there can be clues on the blood work as well.
Excellent. So I'm still checking if we are receiving any more questions. We still have like few minutes. Maybe if you have any thing that you want to add, and you think that the participant will like benefit from these topics, or answering certain to tap on certain areas.
I thank everybody for their attendance today and their interaction and excellent questions. I think one thing I'd probably say is to always pay attention to patients and caregivers out there, to pay attention to your mental health along the way. I think we focus a lot on physical symptoms and on the physical treatment of the lymphoma, which of course we have to, but it's a very it's a challenging journey. And in particular, one thing I've noticed is it can sometimes, from a mental health perspective, be even harder after you finish treatment. Like that last question, wondering about how do I know if I've relapsed? And I've had lots of patients come to me and say that the anxiety is way worse and it's way harder after they finish treatment, because when you're doing treatment, it's kind of you're seeing your medical team all the time, you're doing something, and then you stop and you're kind of just waiting. So, chat with your family doctors, your nurse practitioners, your family along the way, and keep that in mind.
Thank you for the advice. I see here another question. For stage 4, would you recommend EV-AVD or Nivo-AVD as first line? Dr. McDonald shared the latest news about Nivo-AVD, and it seems interesting.
Yeah, no, that's an excellent question. I think we're headed towards Nivo-AVD. That data is looking very encouraging. That trial that Dr. McDonald recommended. Right now, it's not available in Canada yet, but we're headed in that direction. That being said, outcomes with BV-AVD are still excellent, and that would be considered the standard of care as of right now. But it's always exciting to see that we have newer treatments and improvements in treatments coming all the time.
Amazing. So I will be watching if we receive more messages or questions from our audience. We still have like a few minutes to answer your questions, so please don't hesitate to share your thoughts with us.
Yeah, and if you have any follow-ups to any questions you asked earlier, or if my answer wasn't clear or didn't completely answer it, feel free to just pop a follow-up in, no problem.
Excellent. So I think it's time to conclude. So to conclude this Q&A session, I would like to thank Dr. Joanne Hickey for taking the time to participate in today's conference session. We hope those watching today learned something new about their and their loved one lymphoma subtypes. Please turn into the next session titled Symptoms and Side Effects Management for Lymphoma Patient. And thank you everyone for joining us today. Thank you.
It's my colleague from Newfoundland is doing that one, so she'll take good care of you like she does all of our patients on the East Coast. So enjoy.
Amazing.
Thank you so much for the invitation.
Thank you. Bye.
Take care.